everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, is pleased to welcome you to this, our final EDDS Presents webinar. Our NIDA project scientist is Moira O'Brien, and I believe she is in the audience with us today. My name is Erin Artigiani, EDDS Co-I. Barbara Kerr, our digital media manager, and I will be the facilitators for this webinar. We are both part of the EDDS Coordinating Center team, led by Dr. Eric Wish at the Center for Substance Abuse Research, University of Maryland, College Park. Our cooperative agreement for creating and managing the EDDS Coordinating Center ends this month. We are extremely proud to have had this opportunity to work with all of you and are very grateful for the many successful collaborations and friendships, including these webinars, that we have been able to develop together. Through the EDDS Presents webinars, for instance, we have been fortunate to work with leading substance use experts to explore emerging drugs and timely drug-related topics. Today, we are closing out the series with a presentation by the EDDS PI and Director of CESAR, Dr. Eric Wish. He will be presenting on his extensive research with criminal justice and public health populations using urinalysis as a tool for identifying emerging drugs and drug trends. For those who are interested, you can find recordings of this and prior webinars at edds.org. You will also find instructions for how to join our EDDS network and participate in ongoing discussions with approximately 2,000 experts and concerned citizens from across the United States and many other countries. This network will continue after July 31st as the CESAR Research Network, and we look forward to continuing our ongoing discussions on topics such as the impact of the COVID-19 pandemic on substance use. The new EDDS Coordinating Center team, led by Dr. Linda Kotler at the University of Florida, will be launching a website, listserv, and other outreach in the coming days. So please check out the EDDS website for details. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentation. Please do not raise your hand though. Instead, we ask that you post your questions in the Q&A box. We will hold a Q&A session after our presentation. Our presenter, Dr. Wish, Barbara, and I will do our best to get to all of your questions, and we will try to address any remaining questions after the webinar. As I mentioned earlier, a recording of this webinar and a copy of our presenter slides will be made available on both the EDDS website at edds.org and the CESAR website at cesar.umd.edu. Thank you, and we hope you enjoy this webinar. Dr. Wish, the floor is yours.
Thank you, Erin. I'm really pleased to have an opportunity to do this, the final webinar. And I hope all of you can put up with a Boston accent and you'll understand what I'm saying. And I want you to fasten your seatbelts because I'm going to take you on a journey of 40 years of research in this area. I don't know how many of you know, but Dr. Robert DuPont, who I believe is listening, who was the first director of NIDA, introduced urine testing in the court system. It was actually in the treatment agency in Washington, D.C. And I believe it or not, it was April 1st, 1970. It wasn't an April Fool joke. And he created this program, which is still operating today, where anyone who's arrested and charged with a criminal offense in the district is asked to provide a urine sample, which was used then and still now to help people get into treatment and to monitor them during pretrial release. And what I was able to do on a project that was actually funded by Dr. DuPont to another group that I work with was I was able to take the main indicators of a potential heroin problem in the district, this is 1975 to 1980, and put those indicators on the same timeline with the results from the urine testing of arrestees. And at that time, they were using thin layer chromatography, which is a very sort of subjective approach, but heroin would show up as morphine. And what I found was that during this rise or epidemic of heroin use in the district at the time, that the arrestee urinalysis results for morphine bottomed out about a year to a year and a half before the other community indicators of drug use rose. So you have the number of new admissions to drug abuse treatment facilities, number of heroin-related emergency room admissions, and number of heroin-related overdose deaths. So this analysis basically suggested to me and others that maybe if you wanted to know what types of drug problems were coming up in a city, especially with illegal drugs, you might look at the urine testing over time of arrestees in order to have sort of an advanced indicator of drug problems. So literally, since Dr. DuPont created the program, it has continued to this day. It's now run by the Pretrial Services Agency, and their database only goes back to 1984, but I want to show you a couple of things. These are adult arrestees tested, and it was not just people charged with drug offense. This is any type of offense that people were charged with. And I want to show you that in the 80s, notice this graph of cocaine going up like this. This was the cocaine crack epidemic in the late 80s in the district. It showed up beautifully in this data system. And Jay Carver, who ran the agency at the time, wrote this amazing memo early in the mid 80s where he said, if what we learned about the heroin problem in arrestees in the 70s is true, we are probably on the verge of a major uprising in cocaine use in the district, and that's exactly what happened. The other thing I want to point out to you is, notice PCP, which got as much as 40% testing positive, and then it's been sort of cyclical. The other thing I want to show you is, and we're going to get back to this, this is the opiate screen, which picks up primarily codeine, morphine. Look at this over time in the district. It's actually down to 3.9%. Having been as high as 20%. We'll talk more about this later. This is amphetamine positives. And the other thing I want to just show you is we talk about the cocaine crack epidemic, but notice it did end. Notice that you're way back down now to below where it was when it started. You're down to about 14% of arrestees in the district now test positive for cocaine. So really, if you want to think of a successful response that brought down cocaine, here you go, you get it. All right, now, these are the juveniles that have been tested, and I just want to show you this. In the 90s, it picked up the rise in marijuana that had happened really beyond Washington, happened around the country. Marijuana sort of took off, and you can see it went from under 10% positive to about 60% positive. And during this time period, in the early 90s, when we noticed it taking off, we wondered why it was happening. So we called down to the people at the Pretrial Service Agency and we said, can you ask some kids what's going on? And they came back with one word, blunts. Do you remember we had a period where blunt cigars were being hollowed out and filled with marijuana? Well, we found, we got early tip to that by these results. And it was kind of amazing that at the time that we found that, the Washington Post published an article just marveling at the return of cigar sales and how cigar sales were rising in the district at the time. But we knew what the real reason was. And I also want to point out to you that right now, the percentage of juveniles in the district testing positive for marijuana is at all-time high, suggesting that with the decriminalization, legalization of marijuana in the area, that you're getting a lot of the kids coming in and testing positive for marijuana. All right, so I published these results. It was a project that was funded by NIJ, and we looked at the urine tests over time and its relationship to crime. You can get this article, I think it's somewhere in archive. All right, so I moved from Washington then to New York when I finished that study, and I remember at the time I was working with NDRI, which was the biggest NIDA-funded group of scientists in the country, research scientists, and I remember we had Bruce Johnson, the late Bruce Johnson, and Ed Preble had a storefront out in East Harlem where they were interviewing people about their drug use and crimes. Basically, they came into a storefront every day and we paid them to tell us what crimes they had committed and what drugs they were using. And I asked Ed Preble and Bruce, could we go in and collect some urines from them and urine specimens? And Ed basically thought people would be offended if we asked them for urine specimens. But I said, go ahead and offer them $5 to provide a specimen, and they all provided specimens. And when we compared the results that we got back from the New York State laboratory that was testing them, we found that even though most people were saying at that time in the mid-'80s they were using cocaine, almost none of them tested positive. So we had a conversation with Doug Lipton, who ran the research office at the time, and he looked at the results and he says, "I'm going to have to close down your research if people really aren't using these drugs." So I called Dr. Sal Muley, the head of the state laboratory, and I said to him, "How do you test for these drugs?" And he says, "Well, we test everything by thin layer chromatography, or TLC, and then if it's positive, we reconfirm with the more sensitive emit test." So I said to him, "Why don't you try testing all of them with emit?" And when he did, we found just about everyone tested positive for cocaine. And that led to a large study we did of where we collected urines from over 4,000 arrestees in Manhattan Central Booking, both males and females. And we were showing basically that you could go up to arrestees in a city unlike Washington, where they never had this type of program, and that it would be feasible to request and obtain urine samples for analysis. We showed it was possible. And at that time, this was the mid-'80s, we found about 40% testing positive for cocaine. So then the crack cocaine epidemic hit, and NIJ said, "Can you go back in, even though you finished your study, could you go back in and collect some samples and test them for cocaine and see if you pick up more?" And when we came back in there, we were amazed to find 80% testing positive for cocaine. That means that 80% of the arrestees, regardless of charge, had used cocaine in the last couple of days. So that led me to apply to and go down to NIJ as a visiting fellow from 1986 to 90 to basically set up a national program that was called the Drug Use Forecasting Program. In '86 I started, and then it later became redesigned as the Arrestee Drug Abuse Monitoring Program, or ADAM, in 2000. And basically what we did is we trained research staff to go into booking facilities and collect voluntary anonymous urine samples, much like we had done in Manhattan. And someone had once said, if you could do it in New York, you could do it anywhere. And every city we went into, the police said, "You'll never get them to do it." And every time we got them to do it. And unfortunately, the program was launched at NIJ, and then there were changes at the top, and NIJ is really not a drug agency, and it changed as each director came in. They didn't like their budget going to DUF or ADAM, and so the program was actually ended in 2014. At one time, it was in 35 sites, and there were even some international sites. And the NIDA, Community Epidemiology Work Group reporters, loved to use the ADAM DUF data because you could really have an objective measure of what people being arrested had used. I will add as a side two things. One is I actually met with Bill Pollan, who was director of NIDA at the time, and talked to him about this, but things moved slowly. I couldn't get him to fund this, and I eventually had an airplane ride with Chip Stewart, the director of NIJ, sitting next to me. I went over the idea, and within a year, I was back at NIJ as a visiting fellow launching the DUF and ADAM program. And a lot of people keep talking about the need to have ADAM brought back. And I think that would be a great idea, but I don't think it could be done like it was done before. And you'll see what I mean in a few minutes. Anyway, I just want to go back and just tell you that when I started DUF, I would call the lab and say, "Test for 9 drugs." And that was it. And you could pick up basically what people are using. Now you can't do that. Now you have to test for over 200 drugs if you really want to get a picture of what people are using. So after the DUF ADAM program ended, and I was at the University of Maryland here, we started something called the OPUS program, Offender Population Urine Screening. And how this happened is that Aaron, who introduced me, and I were visiting a jail. We visit a lot of jails professionally. And people know my reputation, so they say, "Come here, Dr. Wish, and look at our urine testing." So they brought us into a local jail urine testing lab, and they had wonderful equipment. And then I asked them, "What are you testing for?" and they listed about 9 drugs, and they were the drugs that I used to test for in the 80s. And, you know, they were testing for the old epidemic. And so I then said to them, what do you do with these drugs? Well, first of all, I said, can you test for more drugs? They say, no, we have a state contract. We can't do any more than this. And I said, what do you do with the urines? And they said, the ones that are positive, we hold for 30 days. The others we throw out. So you can guess my next question, can I have some? You know, that was the birth of a whole new idea, which I wish I had known when I was at NIJ. Instead of going into our SDs and having to spend all the time and money of sending people in there to request urines, why not take advantage of the thousands of urine samples being collected from probationers and parolees around the country, and probably millions of specimens, and test them. So in Maryland, we know the probation collects about 500,000 specimens per year from probationers, but they again tested for 4 to 5 drugs: opiates, marijuana, cocaine, benzodiazepines, and PCP. So we decided that we would get the urines and then send them to another laboratory. And we did this in 2008, and we sent them to a laboratory, and back then it was just the beginning of the explosion in the different drugs. So we tested them then for 31 drugs. We thought we were really state of the art back then. And then we got the results back. And I can't tell you more about the design right now, but I want to tell you that we did this in Maryland with 2 samples representing probationers in Baltimore, both in 2005 and 2008. And the interesting thing for us was that we found a significant increase, almost a tripling of the people testing positive for buprenorphine in the 2008 study. And at that time, buprenorphine was just being rolled out as the drug treatment of choice in the Baltimore area. And so it seemed to me, based on the earlier stats that I showed you from Washington, that boy, if it's almost tripling, does that mean we're going to have sort of an epidemic of buprenorphine use in the Maryland area? So we presented this to the House of Delegates, Aaron and I, and then we couldn't really get anyone interested in funding any research on it. So basically, Aaron ran a little study up in a couple of the probation departments. I think it was one probation department in Baltimore, where according to our study, a lot of people were testing positive for buprenorphine. And basically, she went out and interviewed 15 people, probationers, who the probation office said would be knowledgeable about the drugs being used. And what she came back with was that buprenorphine was being sold on the street and it was widely available. So we published this rapid communication on the potential emerging buprenorphine epidemic in the United States. We know buprenorphine is widely used. We know it's much safer than heroin, so a lot of people aren't concerned about this. However, I do know that it is smuggled into prisons and jails, and it's been a problem there. But anyway, we'll wait to see if buprenorphine will become a bigger problem in our society. All right, so we did that study in Maryland, and then we went to ONDCP and we said, you know, we have a new model from the DUF Atom program that you used to fund at one point. We said, you could, we would love to set up a program now where we collect urines from criminal justice and maybe hospital testing programs. We'll test specimens that the group said had tested positive for any drugs they tested for are totally negative, and we'll send the specimens to a laboratory, and we'll compare the results, and we'll be able to give each agency that sends a specimen some idea of what they were missing with their testing, because again, they were only testing for a small number of drugs, and we were going to test for a lot more, and we would prove the feasibility of this as a drug monitoring system. So it was funded by ONDCP. There were specimens collected by criminal justice programs and hospitals. They were de-identified specimens, so there was no big IRB issues. We took them, so we stratified by positive or negative for any drug they were testing for and retested them. We've seen 2013 and 2019, we went into a lot of different sites. We went into Washington several times. We went into Virginia, Maryland. We went into the HOPE program, which is an innovative probation treatment program. We went into 2 prisons in Ohio. We went to, in Tampa, with the help of Dr. Richard Dembo, we got access to juveniles and tested them. And by the way, we found a type of drug, a synthetic cannabinoid that they weren't testing for, so they now added that to their panel. We went to the Denver Drug Court, and I'm not going to go over the results. I'm just going to, you can get them all online, and basically we're able to show these programs what they were missing, and some of them changed their programs, their testing programs by that, and it gave us a good idea of what was being used, at least by people who were in the criminal justice system. I want to go back to something I said. With the DUF, you know, test for 9 drugs. That's all you have to do. Now, in order to be able to test for as many of the different types of drugs that people might be using, we literally instituted a set of people that we would go to find out what drugs around the world, what drugs do they think are showing up, so that we could then talk to our collaborating laboratory. Our collaborating laboratory now, since the start of ENDUS, has been the Armed Forces Medical Examiner System, or AFMES. They're local. They do all the testing for the urine specimens for the military worldwide, and they have been a collaborating partner with us on a lot of our research, and they test specimens for over now 240 drugs. So we talked to them, we talked to Cayman Chemical, we talked to DEA, we talked to NIDA scientists, people at other laboratories. You can see what we do. And then once we find out what metabolites we should be testing for, my program manager on this, who speaks the lab language, is Amy Billing, and she basically talks with AFMES, and they work out updating their panel to include these drugs. And they love to work with us because we help them to find out what drugs to potentially test for, more so than they can find generally in the arm by just looking at what the military population is testing positive for. So it's a whole different ball game now than it was when I started doing this research, or when Bob DuPont started his program in the 70s and 80s. All right, so we test for now for 240 drugs, 46 synthetic cannabinoids, 21 fentanyls and fentanyl analogs, 95 other new psychoactive substances, and 78 illicit and prescription drugs. And believe me, the technology of testing is changing so fast, we'll be able to go beyond this. There's now an ability to test for over 200 synthetic cannabinoids with the time of flight procedures that are now coming on stream, no pun intended. Now, so when we had the CEDUs going, we could then compare over time what types of drugs were out there being sold as synthetic cannabinoids, or quote, synthetic marijuana, which is what the layperson thinks of. I want to show you this because this is 3 times we went out in DC, and these are the specimens that tested positive for any synthetic cannabinoid metabolite. When we started out, what we were told to test for was UR144 and XLR11. Those were like the first synthetic cannabinoid out there. And by the way, I'll tell you this little story. When we got our first specimens to test, we called the lab and we said, test for these 10 synthetic metabolites. And the chemist came back to us and said, you know, if you test those 10, those are the old ones. They're now illegal. It's the new ones you have to test for before they become illegal and get scheduled. So he said, add UR144 and XLR11. So we did that. And it turns out if we had not added those 2 metabolites the first time, we would have missed 95% of the positives that we found for synthetic cannabinoid. That's how quick you have to move to catch up with the changing nature of these drugs. So when we started the first time in 2013, it was 91% UR144 and 40% XR11. Look at this. By the time in 2017, 4 years later, it was 42% UR144, 26% XR11. And look at this, AB Pinaka, which we didn't even test for in CEDUS 1, which was 0 in CEDUS 2, by CEDUS 3 was 65%. Same thing with AB Chimanaka, metabolite 4, 77%. So if you really want to know epidemiologically what's out there and what people are using, you have to do this comprehensive urine testing, okay? I want to also show you this. This came from a study we did at probationers in Maryland, and these were the 21 specimens that contained fentanyl. I just want to show you this theme that when you find fentanyl, you also find morphine, which probably came from heroin, and codeine. There is the heroin, but heroin metabolizes quickly to morphine. That's why you don't pick up as many. Notice that in these 21 fentanyl positives, you find, again, this is in Maryland, you find almost a third of them testing positive for cocaine. And I can tell you around the country, when you find fentanyl, you find a significant proportion also testing positive for cocaine. You had 5 marijuana, you had 7 methadone, you had 3 buprenorphine. So we have all of this published, and you can see this. And I'm going to move on because we keep finding this theme over and over again of multiple substances in the urines. All right. So while we were doing these studies, in the CEDUF studies, there was an outbreak of synthetic cannabinoids in Maryland. So we went back to 2 hospitals and we said, can you collect specimens from patients coming in with a suspected synthetic cannabinoid overdose? All right. And get those specimens and send them to us, and we will do expanded drug testing and see what they're using. And we did, this study was played up in the press when the doctors released it, because here you've got, remember, you've got patients coming in where people, either the patients or the doctors or observers, thought that they had a synthetic cannabinoid related overdose. When we tested them, we found something very different. And by the way, this is one reason the research being done, which just attempts to find out the drugs involved in overdose cases by looking at the clinical records, they're potentially getting inaccurate information, because the information in the clinical records oftentimes is not based on the type of toxicologic testing we're doing. And so people, doctors and physicians are claiming that they're seeing a particular drug, but it's not that. So what did we find? In these patients where they were sent to us because they were believed to be using synthetic cannabinoids and having a problem, only 1/4 tested positive for synthetic cannabinoids. For the Prince George's County, where there's a ongoing PCP level of use, we found 47% of the specimens tested positive for PCP, and in Baltimore, 51% tested positive for fentanyl. All right, I want to show you this in a minute, including both fentanyl, non-fentanyl, and fentanyl opioids. I want to show you the results in the next table. All right, so these are the people in Prince George's Hospital Center, and these are the people in the Baltimore Hospital. Notice that, again, 2 groups of patients that were believed to be having used synthetic cannabinoids, over 60%, look, have used marijuana, tested positive for marijuana. In Baltimore, 46% was cocaine. In Prince George's, 22%. But look at PCP, 47% PCP in Prince George's County, almost none in Baltimore. And I want to just tell you, doing this over my entire career, it's not unusual to find different drugs being used and different test results in cities that are as few as 40 miles apart, like Baltimore and Washington. Drug use is a local phenomenon. All right, notice that 28% tested positive for fentanyl. In Baltimore, only 4% in Prince George's County. And I want you to notice here, very important, look at the percentage that tested positive for 3 or more substances, 33% in Baltimore, 24% in Prince George's County. This is what we find repeatedly. And I know what you're going to say. You're going to say, of course, Dr. Wish, you're looking at people in hospitals. You're looking at, it's a very biased sample, and you're looking at people in the criminal justice system. That's a very biased sample. So let me show you this. As part of NDUS, we were doing a hotspot study of the huge fentanyl rise in fentanyl-related deaths in New Hampshire. And Marcy Sorg, Dr. Sorg, worked with us, and she helped us to get, we wrote a report on this, but she helped to send to us 136 urine specimens from fentanyl-caused overdose deaths. So these are specimens that the medical examiner has ruled is a fentanyl-caused overdose death. And of course, when we tested them, almost all of them tested positive for fentanyl. But look at this. 38% tested positive for marijuana, 37% cocaine, and all these other drugs. In fact, you find, if I add this up, what, 60% had 3 or more substances in the urine. So, and the average was 2.88. So I think I have a real problem when we come out with results saying X number of cocaine caused deaths, or X number of heroin caused deaths, because it's not, we don't stress enough that the person who had fentanyl in them also had 2 or 3 other drugs with them. So to just call it a fentanyl death and account it that way is really a misattribution of what's going on. So anyway, I wanted to show you this because it's been the case everywhere we looked, and I'll show you some more populations now. So here we are doing the CEDUF study with a small number of sites and basically collecting up to about 200 specimens de-identified and testing them. So we knew from people who contacted us that there was a real need by a lot of treatment programs and hospitals and medical examiners for an ability to be able to test for the types of drugs we were testing for. So with NIDA support, we did a pilot study called the Drug Outbreak Testing Service. And with that, we allowed sites to send in up to 20 de-identified urine specimens for free testing for 240 licit and illicit drugs. It was always de-identified. The results were given in an aggregate way so that you couldn't identify people. And we presented the results so you could see what was in each specimen. This is a summary. We actually had 13 sites, but I found this slide we have looking at, notice the different types of groups we had. Opioid overdose patients in an ED. In Palm Beach, Florida, uninsured opiate users in opioid treatment. In King County, deceased opioid overdose cases. Opioid positive cases in residential drug treatment in Texas. Treatment program patients with suspected fentanyl use in Burlington, Vermont. In DC, persons under criminal justice supervision, and then we did some uninsured, publicly insured persons seeking behavioral health services locally. This is the average number of different metabolites found in each of these samples. So everywhere we look, we find a whole lot of metabolites in these specimens. And let me just tell you, because some of you are thinking, well, maybe they didn't intentionally use all these, and you're actually absolutely right. It used to be when we did testing and we found a drug there, we pretty much would say the person used it. But now the drugs are so adulterated in terms of production, and there's been such an explosion in the metabolites that people may go out and think they bought drug X, but it may also have drug Y and drug Z in it, and they also may have been transported in such a way with drug Y and drug Z. So we don't know fully that people use all these drugs. In one of the specimens, I had 18 drugs tested positive in one of the DOT specimens. Do I think that the person took 18 substances? I don't think that's likely. But we do have a lot of drugs that seem to go together that we find. Okay? So why is this happening? Why are we finding so many drugs in people who are using the opioids? Well, this goes back to when I trained with Dr. Lee, the late Dr. Lee Ann Robbins at Washington University Department of Psychiatry, and she ran the classic Vietnam veteran follow-up study where we followed up a representative sample of Army enlisted men who left Vietnam in September, I think it was 70 or 71, and followed up 94% of them and did extensive life history interviews. Anyway, what she found in an article that we published and republished recently was that people who were using heroin reported using a lot of drugs. And the way that she characterized it is that heroin had such a reputation in our society that it filters down, that those who use it have used everything else. And we could debate that issue. But I want to just show you an analysis that I've done a number of times. And we call it in the office Wishes Law. And this is it. If you take the household survey and you line up the drugs by prevalence, every use, from alcohol to heroin. So it goes from high use, high prevalence to low. What you find is you go from high to low, the mean number of drugs reported goes from low to high. So that the people who have used, who report using the rarer drugs, that's with a Boston accent, R-A-R-E-R, the people who've used these rarer drugs have used everything else just about, okay? The correlation between the prevalence of a drug in a population and the number of drugs reused is minus 0.95. I have done this over and over. I've done it with monitoring the future data. I've done it with other years of NISDA. What it suggests to me is that people who go on, who use the rare, less common drugs, for whatever reason, whether it's biologic, behavioral, learning, I don't know, our availability, are likely to have used the more common drugs. There's almost like there's some disposition to use these drugs. And for that reason, I am sort of opposed to naming drugs by a single drug epidemic like the opioid epidemic, when in fact, when we find opioids, we find generally it's the tip of the iceberg of the drugs that people have been using. And they tend to have a long history of drug use. And I would suggest that people look at studies and look at that and do the life history research. Most of the people I've studied and I've seen, as I say, if they use these drugs, they've used everything else. And as we know from the great work that the NIDA scientists with Wilson Compton did, the probability of someone going on from the opioids to heroin is like in the 4 or 5% range, if I remember correctly. So the people who are using these drugs tend to have had a history of other drug use, okay? Now, I want to get to our latest new thing. I'm sorry, there's a problem on this. Nope, I guess it's gone. So, we're always looking for how can we take advantage of the data that exists. I told you that we've taken advantage of the urine specimens that are already collected by hospitals and treatment programs, and we test them for more drugs, and it's a wonderful indicator of what's going on in terms of drug use. Well, because of our work with the hospital that I told you about, the collaborating scientists there, we started asking questions, and we found out that these hospitals in Baltimore and the ones locally in Prince George's County both use electronic health records to store their urinalysis results. So wait a minute. The hospitals have all of this information there and no one's using it for epidemiologic purposes as best as we can tell. So we started something we've now called the Emergency Department Drug Surveillance Program, or EDDS. And what we do is first we have to find collaborating visionary scientists in the medical school, or in the hospital centers, the EDs, and they have access to these results. So we work with them to get IRB approvals, which sometimes takes a while. And we now have 7 hospitals in Maryland who every 3 months give us exports of their urinalysis results for people that they test, which are largely people who come in from an overdose-related incident, they think, or because they have some psychiatric issues that they think maybe the person has been using some drugs, okay? So I'm really excited about this because when you think about it, most of the data systems we have in epidemiology, especially put out by the government, you're lucky to get something that's within the data are within the past year. With this system, we get up-to-date data every 3 months. So let me show you what we did. This was 4 hospitals in Baltimore, and what we found was these are from 2016 to 2020. Notice that our most recent findings are a month old, April through June. And I want to show you this because we looked at this, and I know, by the way, you're going to say, well, Dr. Wish, you only got a few drugs. Yeah, they only test for 8 drugs, and these are the more prevalent ones, but I'll get to that in a minute. But anyway, look at the opiate results. Here, Baltimore is in the middle of an opioid problem, and the opiate results are like this. What's going on? All right, that was the 4 hospitals together, so we broke them out. All 4 hospitals, the opiate positives are going down. So we talked to the doctors and we said, you know, what if people are using fentanyl? because we know the opiate screen, which goes back to what I used in the 70s, what the labs use, doesn't pick up fentanyl. Can you imagine that hospitals are using an opiate screen during an opioid epidemic that can't pick up fentanyl? During a fentanyl epidemic. So we talked to our collaborating scientists, and they did a study where they took about 100 samples and they did a dipstick test for fentanyl, and then they sent them to the lab and they compared the results, and they found out a lot of these people tested positive for fentanyl and a lot of them were missed. They tested negative by the opiate screen. So these two, so what happened as a result of these results, but it's really exciting when you're doing state-of-the-art epidemiology, real time, that your results can be used by a hospital to plan what they're going to do with their patients. So 2 hospitals decided to add fentanyl to their routine screen. So this is what the 2 hospitals combined look like up until December 2018. All right, so here's your opiate screen coming down. All right, so this is all they thought their patients were using. So now add the fentanyl results. I think this is so amazing. So they started testing positive for fentanyl in January 19, and look, fentanyl is between 70 and 80% positive in these hospitals. That's just, for me, that's phenomenal. Then, and think of how using our science and our tools to help a hospital to determine what they should be testing for. So that's what happened here. All right. And as a result of this, we published in the Notes from the Field recently, sorry, that was my cursor. These results are in the MMWR. Our article was just published a few weeks ago, and I suggest you might want to look at it, and it'll tell you more about what we did. And I'm really proud of the scientists who did this. All right, so I just want to show you Baltimore is different than Prince George's County, which is 40 miles away also. And there we find marijuana is the drug that we find the most test positive for. And by the way, these results don't compare the numbers, because in Prince George's County, they give us only positive results. So this is percentage of positive tests that were tested positive for marijuana. I just wanted to show you that it's sort of sloping upward, and we want to know, why is it that why is it that it seems like marijuana is increasing in people coming into this area for an overdose? And we think there should be a research study. We're trying to fund a study to ask prospectively patients who tested positive for marijuana, to ask them if it is in any way involved with their ED incident that they came to the ED for. This is another way of presenting them. This is the range of percent positives in different hospitals in Prince George's County. The lowest point of testing positive, the highest in the current. So you can get an idea where we are in that range. All right, now we did another study. I'm telling you that we are doing the EDDS study, and in one hospital, we asked them, could they send us de-identified urine samples that we could test for 240 drugs, that we could compare to the samples, to the results they had given us to EDDS during the same time period. So let me say that again. We had in EDDS for a given time period all their exported urine test results during that period. We then wanted to compare that with a sample of patients who came in to that same hospital and who gave urines during that period. We collected 150 consecutive urines, and we asked them to label them as having tested positive for anything in their limited panel or negative. All right, we just wanted to do this as sort of a validation study of what we got in EDDS versus what we would get with our testing. So these are the 8 drugs that they test for. This is what was in EDDS for the 169 positive specimens. Remember, they only send us positive specimens in this hospital. This is what we found, and this is what we found when we got 105 separate patients' urines during the same period. And you can see how similar the results are, except for cocaine. Now, why is it that our laboratory found almost twice as much cocaine than their testing did? Well, you have to go to the level of detection. And what you find is, for cocaine, the test in the hospital could pick up 300 nanograms per milliliter, but our lab could pick up as little as 25. So the probability is we were picking up, because our lab was using more sensitive tests, that's why we were picking up much more cocaine. Furthermore, notice how much more sensitive the marijuana tests were. I'll get to that in a minute. So then we compared, the final thing we did is we compared all of their specimens that we had tested, that they said had tested positive for anything, with the set of specimens, 49, that they said tested negative by their screen. And what we found is we found very few drugs in the negative, except in terms of the illegal drugs, we found 12% marijuana and 8% cocaine. So basically what we're saying is, in the people who tested negative by their hospital's entire screen, about 12% would have tested positive for marijuana and 8% for cocaine if they had used more sensitive tests. And I don't know if it's important for them to know this, but what we recommended to the hospitals is they could increase the sensitivity of their marijuana and cocaine tests if it was important to pick it up among people who tested negative on their current screen. So I wanted to show you this. I hesitate to show you this because it's really, you notice up here it says draft. This is not ready for prime time, but I wanted to show you one of the benefits of having an almost real-time data series. So this is basically weekly results from the 4 Baltimore hospitals, and it shows the total number of drug overdose ED visits, related ED visits, the total number with drug tests performed, and the 7-day moving averages of each. And all I wanted to show you is the doctors gave us the results through early June. So it coincided with the upswing of COVID in Baltimore. This is when Maryland started the stay-at-home order. This is when it ended. And I'm not going to make a big deal out of these results yet, where it looks like things came down, because we're just starting to analyze it. But we want to look at things like, did the age distribution of people coming in during COVID change? Did the drugs they were testing positive change? We're even going to look at, was the geographic area that they came from change? These are all things that we're hoping to find some funding to look at in the near future. But all I wanted to do was to show you this as an example of, if you have a near real-time data series and you get something strange happening, a different drug outbreak happening or whatever, you could use the EDDS system. And by the way, going back 1 minute, sorry, having done this, it can now show you whether or not the hospital needs to test for any of these other drugs. Note that all these other drugs that we found, most of them occurred in people already testing positive. So the hospital would have to weigh whether or not they need to change their testing panel. All right, so my conclusions. I think that this 40 years of research has really shown that urinalysis results can be used for epidemiologic purposes. And I want to just say this to those of you who use primarily self-reports. I know I and the new head of EDDS, Dr. Kotler, we were trained by Dr. Lee Robbins at WashU on self-report life history research. We both know the value of that for measuring a lot of things with people. But what I want to tell you is, given that people, users, can't possibly know what drugs they took if they were bought on the street or over the internet, then if you rely totally on self-report, you are getting self-reports of probable drug use or what the person thinks they used. But you really need to do this testing to know what in fact is out there and what people used. And by the way, the ED physicians oftentimes say, we don't need the results right away because we treat the symptoms. But if doctors got the results, even if they're delayed, if they got the results of the comprehensive testing, they could then say to their patient population, you know, we found that other patients who are testing positive for fentanyl, we're also using cocaine or using some other type of metabolite. And you may want to know that if you're using other drugs, that that's likely to be out there and mixed in. Second, the types of laboratory testing we have done is not available to most organizations. If we really are serious about knowing what drugs are out there in this day and age, we probably should set up a system whereby people who collect urines, whether it's hospitals or drug treatment programs or criminal justice programs, should be able to send in specimens like we did with DOTS and get some idea of what the drugs are that their population is using. I think it should be a nationally funded system because people can't afford to do this. In addition, because the hospitals already have these data in electronic health records, they have the urinalysis results, and national EDDS systems should be created to make these results available, not only to the hospitals, but to researchers like all of you and us, so we can be on top of what's going on. And I told you already, EDDS, I hadn't predicted this, EDDS opens the door to research with your hospital physicians as problems emerge like COVID. Because since we've been working with these doctors in the hospitals, we have an open door to do other research projects with them. It is just a bonanza for doing research. For more information, you can contact me at ewish@umd.edu, or you can contact CESAR. Go to our website where a lot of this material will be there. I want to thank you to NIDA. I want to especially thank Moira O'Brien, who was the project scientist who helped us to support and give us ideas for a lot of the things we do. I don't think there would have been DOTS without her and her openness to it. And I want to thank our NIDA project officer, Marsha Lopez, who has been a phenomenal support and for helping to make this webinar series such a success. I also have a list of people I got to tell you about who helped make all of this possible. I know, Dr. DuPont, you're out there. I'm telling you that all of this stuff I did really came about because of his visionary addition of urine testing in the District of Columbia, in the treatment agency there. He had the vision way back then to start the testing in order to find out the relationship between drug use and crime and how it showed up and the people being arrested in the district. And I like to say he has the ideas and I try and run with them. I want to thank Dr. Kathleen Stewart, has done a lot of basically geographic analysis, spatial analysis with us, especially on the hotspot study in New Hampshire. I want to thank the two doctors in the hospitals, Dr. Brad Schwartz and Dr. Zach Desmond, who made the EDDS studies possible. I want to thank Dr. Andrea Lopez, an anthropologist who did the wonderful qualitative hotspot study of methamphetamine and opioid use. I think it was in Oregon, and I recommend you go to that site. I want to thank the late Dr. Leanne Robbins, and I just hope she's proud of the way that I, as her student, used the tools that she so freely taught me. Finally, the ability to do endos has a large number of people. I'm going to mention them by first name. They're at CESAR, and it's Aaron and Amy and Maggie and Ebony and Mike and Wanda and Barbara and David and Marwa and Julie and Debbie and Sandra and all of the students who came through CESAR learning through endos and who got their public health internships done working with us. I want to thank you all, and all of you who stayed. I hope you didn't fall asleep. I hope that you will pursue some of these ideas, and I want you to know that all of us at CESAR are looking forward to working with the new endos team at University of Florida, led by the very able Dr. Linda Kotler, to make endos an even better project than it is. So thank you.
Thank you so much, Dr. Wish. That was really a great presentation. It was very comprehensive discussion of the various ways of using urine testing and other resources like electronic hospital records to track trends, and sprinkle along the way with some nice stories. And so I'm sure all of that has engendered a lot of thought and discussion among our viewers. And I can see that we do have some questions coming in, so I want to remind all of you to please submit your questions through the Q&A box in writing, and I will read them out so Dr. Wish can respond to them. And we are getting near to the end of our scheduled hour, so I hope that you will stick around because you don't want to miss our ongoing discussion here. But we will put a recording of this webinar and a copy of the slides on probably on both websites at ndus.org and the CESAR website at cesar.umd.edu. So our first question is about legislation, and it is, with juveniles testing positive for marijuana at an all-time high in 2020, this would be in DC, would it be fair to mention the unique marijuana laws in DC, which is significantly less than decriminalization? So I guess the question is, do you think that could have had an impact on what's going on?
Well, I just want to alert you that the numbers of juveniles being tested has fallen way off from the way it used to be. So I'm not sure if that affected the results. I think it needs to be looked at. But Aaron, you're really my policy person who knows about the laws. Is there anything you can add about the DC laws in terms of this?
Well, DC is a complicated geographical location for looking at marijuana laws because it has that combination of local areas and federal land and the differences in what's allowed in the two there. So I would expect that there could be some impact perhaps from what's going on with the laws, and there may well be some research that we could find that we could share on the website as well.
Yeah, we note that again, that we found in the Prince George's hospitals and all of them that marijuana was the drug most likely detected, and it's trending up. So we actually have a small grant application in to the university. I don't know if we'll get it, to try and go back to those hospitals in Prince George's, to that hospital, and try and ask some people who test positive for marijuana if the marijuana was related to the ED, because it's just as likely that marijuana use has climbed so much in the area that everyone's using it, just like more people are using it, just like more people were smoking cigarettes at one time. In terms of the laws, I don't know what to make of the DC juvenile test. No one else is talking about this increase, and I don't know if anyone really is concerned about it. It's I guess you would expect, as the drug becomes more available in a community, that the kids who are arrested are probably more likely to be using it. And we had found that before with juveniles testing, that you found a lot of marijuana. You generally don't find anything else but marijuana, by the way, in juveniles. You don't hit the opiates until 18 or later. You have another question?
So our next question, I believe, is about wastewater testing, and actually our wastewater expert in NDUS is Dr. Caleb Bantagreen at the University of Washington, who's done a great deal of research on this and also serves as our Sentinel Community Epidemiologist for King County, Seattle area. So you may well be interested in looking up some of his research. But this viewer was asking for your thoughts as well, Dr. Wish, on evaluating drug analyses using city water systems.
You know, I thought I was being avant-garde by looking at urine. Now you're asking me to look at more bodily waste. I think there's something to that. I did see a couple of presentations where I really could understand it. It seems very hard to think about how you could do this, but I know it is possible. And I haven't really studied it, but I think that the people, Caleb and other people who are doing this work, should be given an opportunity to show its value in this country. I mean, because there are, especially, I know it can be used in institutions like jails and prisons, where you might be able to get the sewage offshoot from those institutions and contest that. When it becomes a whole city, I don't understand totally how definitive you can get, other than saying that it's there in the sewage. So I think it's a great question, but I have limited knowledge in being able to address that. And I do recommend that people contact Caleb. And I do believe we have a webinar on on this topic, don't we, Erin?
Yes, I think that's true, and you would find that under resources and NDUS presents webinars in the webinar archive on the NDUS website. And I want to thank those of you who've been submitting in some nice compliments to us. We appreciate your kind words and your encouragement, and we look forward to continuing our work as we go forward. And I will move on to our next question here, which is from a viewer who says, given the regional and local nature of drug use, isn't too much money and emphasis placed on national estimates? So that's an interesting question, because that gets at a lot of what we do at NDUS in terms of looking at our sentinel sites. And
Thank you. That's a fantastic question. I really appreciate it, because when I was establishing the DUF, which became ATOM program, people always wanted one number. And one number is totally misleading when it comes to drugs. Drug use is local. And whoever asked me this, you're absolutely correct. We should be looking at estimates that are more regional. And I think that, by the way, is one of the pluses of the whole NDUS approach, is that you have 18 sites, so at least you can look at, you will have 18 sites, so at least you can look at what's happening in those specific areas. This idea that you need a single number is misplaced. And it's, again, to me, it's the idea of you want a simplistic answer. You can't do a one number for methamphetamines when we know that methamphetamines are more likely to be found in different areas of the country. To average it out is really to miss the whole issue.
Right.
You know, it's sort of like also as COVID, when you look at it, as you can get a total for COVID, but basically some states are going up and some states are going down. You need to know that local trend.
Thank you. Next, we have a comment here from Dr. Luke Short from Washington, D.C., who is actually the chief of chemistry for the DC DFS, which I believe is the Department of Forensic Science, who mentions we have a unique DC safe law that covers synthetics. Regarding what we're seeing in evidence and surveillance, I agree that most of what is seized is a complex mix. Also, about 70% of all heroin exhibits is actually synthetic opioids or adulterated with it.
Thank you. That's great. I mean, I think, you know, NDUS for many years has been doing the NIFLS data, which is the DEA system of basically, when they're going to move ahead with a case and prosecute it, they may send some of the drug that was seized to a police laboratory that then reports it to NIFLS. And it's really important to know that what NIFLS is reporting is the parent drug in drug seized. And the types of things you find in urine is the metabolite after some people use it. So sometimes you can even find a new drug on the street and you don't know how to test for it with the urinalysis. And so we have to wait for the lab to actually create the standards so they can do the urine testing. But I believe that NIFLS is getting more and more sophisticated about showing, like this specialist did, showing the combinations of the drugs in the parcels they get. Because that's very important, because all we know is we find it, you know, in the urines, and we know that the person was exposed to it, but the parent drug analyses can tell us if before the person took it, are these drugs combined. So we really need to basically pay attention to both types of data.
And our last question here is from a colleague down in Florida who asked Dr. Wish if you have any thoughts on the link between drug use and STI issues.
Oh, I bet you that came from Dr. Dembo.
Yes, it did.
He's just publishing an article on that I think it's in press, showing a relationship between drug use and STIs. I don't do the testing of the STIs, so he correlates them, I don't, but I know there is a relationship, and I would suggest you either contact Dr. Dembo or wait for his article to come out in the very near future. And it's been a pleasure and honor, Richard, to work with you. on this research. He's been with me for many years. I want to just mention that because some of you might be thinking of this. Dr. Kotler has been very gracious in reaching out to us to maybe include an EDDS type study within the current ENDUS project that she's taking over now at the end of the week, basically. So keep looking for that. Maybe we'll be able to add the EDDS type work as a indicator that the sites sites could use as an additional way of measuring what's available in their area through ED patients.
Thank you very much. Once again, Dr. Wish, that was a great presentation, and we really appreciate all the information that you shared today. And we appreciate all of you, our viewers, for sticking around for our Q&A discussion. And we hope that you will stay tuned for future announcements on upcoming developments, both at ENDUS as the transition continues and the University of Florida team take over, and with the rest of us here at CESAR. And
can I say one more thing, Aaron?
sure.
I want to thank Barbara Kerr, who's helped, that's K-E-R-R with a Boston accent, who's been helping to run the webinar series and storing all this. And Aaron, you have done a phenomenal job. And it's such an honor and a privilege to have you working with this project. And I'll just alert people that Aaron has agreed to be on the scientific advisory group for the new ENDUS. So ENDUS is not going to lose her insights and expertise. And Aaron, just thank you.
Well, thank you. I appreciate that. And I look forward to continuing as a SAG member with the new team. And I hope to have the opportunity to work with a lot of you all again in the future. And I hope you stay safe and keep healthy and enjoy the rest of your week. Thanks again for joining us.